Hello, everyone. I'm Leslie Wenstall, the Education and Awareness Team Coordinator at Dysautonomia Support Network, and today I'm joined by Dr. Alan Pocinki. Dr. Pocinki is a general internist who's in private practice in Rockville, Maryland, and he's been interested in the joint hypermobility and related autonomic and sleep disorders since the late 1990s. He regularly speaks on these subjects at local and national meetings. His publications include co-authoring two major 2017 articles on the evaluation and management of fatigue and autonomic dysfunction in Ehlers-Danlos patients, and a chapter on sleep disorders in the Dysautonomia Project. He's received a variety of awards and recognition for service to his profession, as well as for the quality of his practice. Most recently, he received the American College of Physicians Leadership Award and the Ehlers-Danlos Society's Lifetime Achievement Award. Dr. Pocinki is a good friend of Dysautonomia Support Network, and we are pleased to have him with us today.
Thanks, Leslie. Um, Thanks for asking me to speak and making this information available to people since I get lots of questions about it. Uh, so the title of my talk today is The Role and Treatment of Autonomic Dysfunction in Sleep Disorders. And I will be discussing off-label uses of many medications. I certainly have no financial conflicts of interest to disclose. There's no one who has any financial interest in these areas, unfortunately. So, very brief overview. Most of you are probably familiar with the autonomic nervous system and the idea that it regulates all involuntary body processes and also plays a role in regulating sleep. This latter is surprisingly not a universally held belief. I'll get back to that in a minute. Autonomic dysfunction is very common in Ehlers-Danlos syndrome and other hypermobility-related syndromes and underlies many of their symptoms. But today we're just going to focus on sleep. And what I found is that the most common type of sleep disorder seen in the hypermobility syndromes appears to have an autonomic basis. So I get back to this idea that you just heard me say the autonomic nervous system also plays a role in regulating sleep. And that seemed obvious to me. Sleep is largely regulated by the hypothalamus, which also regulates the autonomic nervous system. And as I'll show you later, autonomic dysfunction certainly seems to dysregulate sleep. So it has always seemed pretty obvious to me. But I found in speaking to sleep experts over the last couple of decades that this idea that a lot of them seem to think that sleep is regulated cortically rather than through the hypothalamus, which is in the brainstem. I did finally find, after trying to promote this concept for a couple of decades, a paper published last year in the Journal of Clinical Neurology discussing the interconnection between sleep disorders and autonomic dysfunction, which suggests that sleep and autonomic regulation have a bidirectional relationship. In other words, the autonomic nervous system affects sleep, and sleep affects the autonomic nervous system. And hopefully you'll see that in future slides here. So very basics. Again, most of you are familiar with the idea that sympathetic nervous system is your fight or flight response. I find it helpful to use an automotive analogy and call that the accelerator. The parasympathetic nervous system is the brake, and that's involved in rest and digestion, or at least it should be. So unfortunately, a lot of the hypermobility syndromes are characterized by autonomic instability, which I describe as a failure to modulate response to stress. So the primary job of the autonomic nervous system is to keep things stable, whether it's your heart rate, your blood pressure, your breathing, your kidney function, your digestion, to keep them running smoothly and to avoid extremes and to respond to stresses appropriately. The central paradox of the autonomic responses in many patients with hypermobility syndromes is that the more run down, stressed out, exhausted you get, the more your body over responds to minor stresses. So hence this failure to modulate, the inability to have a small response to a small stress and a big response to a big stress. Instead, everything seems to trigger a big response. And then that over-response to stress often triggers an overcorrection. So things go up too much, then they go down too much, then go up too much. And graphically, see if I can get a cursor here. There he is. So graphically, you see this here. The red is we're measuring sympathetic activity, and the blue parasympathetic activity. And I'll just point out one section of the test here. This is in a healthy person who we have them stand in this part of the test, and in response to standing, there's a slight drop in blood flow to the brain. And so there's a slight but very transient increase in sympathetic activity. And then almost immediately, my disappearing cursor disappeared again. Almost immediately, the body does other things to maintain blood flow to the brain, and the additional extra sympathetic activity is not needed. In this patient, you'll see that when she stands, there's a drop in blood flow to the brain, almost immediately an excessive surge in sympathetic response, and then almost instantaneously a bigger drop. So hit the gas too hard, then hit the brake too hard. Whoop, that's too low, but hit the gas again. No, that's too much gas, better hit the brake again. Up, down, up, down. This person's been standing for about 3 minutes, still can't get her blood pressure, heart rate, blood flow to the brain regulated. The first part of the test here, person's just sitting quietly. And again, in a healthy person, there's no significant autonomic activity at all. But this patient's body decides that they need a little extra adrenaline here, and then that's way too much. So better at the gas, and then it gets too low, and they're sitting quietly. So in terms of fatigue, look at how much energy this person is wasting, just up and down and up and down. And this again is exactly what people would describe to me during the day. In fact, just a couple of days ago, somebody sent me a note, something about, oh, we were talking about this, and she said that she was sitting quietly in her home, and all of a sudden a plate on a shelf shifted or moved a little bit, and that startled her to the point that not only did her heart start racing and pounding, but it was still pounding almost an hour later. So this is a before and after slide that I like to include just to make the point that this crazy up and down that I call the autonomic roller coaster is a temporary thing. There's no permanent damage to anything here. And that with correction of the underlying drivers of autonomic dysfunction, we can get people's autonomic function almost back to normal. So let's focus on sleep now. So misperception is a common problem in people of with all types of sleep disorders. Certainly, a lot of Ehlers-Danlos patients and dysautonomia patients say, I sleep fine. I fall asleep okay, sleep through the night okay. And some people even say, I'm a great sleeper. I can sleep anytime, anywhere. And I have to point out to them that if that's the case, then they probably aren't sleeping very well. So then I asked, do you feel rested when you get up? And the answers are things like, no, I never feel rested. I wake up feeling like I haven't slept at all. I don't think I know what feeling rested feel like. I ask people, when you get up in the morning, do you feel like you just want to roll over and go back to sleep for 2 hours? And they say, of course, doesn't everybody? I say, no, actually, some of us wake up feeling rested in the morning and don't feel like we need to go back to sleep. And just as an analogy in terms of misperception, some studies have shown that as many as 90% of people with sleep apnea are not aware of it. They're sleeping through the night. They don't realize that they're having trouble breathing. So here's an illustration of this. These are sleep stages throughout the night. And normally most people, when they fall asleep, they have some light sleep, then they have some deep sleep, light sleep, REM, light sleep. Usually there's a little more deep sleep here, but it's hard to find a normal. Light sleep, REM, light sleep, REM, light sleep, REM, in a fairly regular cycle through the night. This is a patient who said, gee, I fall asleep fine. I'm not tossing and turning. I'm not having wild dreams and nightmares. I'm not having trouble breathing. I'm sleeping through the night fine, and I wake up feeling like I haven't slept at all. And right away, you can see there's no deep sleep at all. There's almost no REM. This person seems to be just stuck in light sleep the whole night. What you can't see in this study are that in the sleep lab, an arousal is a disruption to the continuity of sleep that lasts less than 30 seconds. and a disruption to sleep that lasts more than 30 seconds is called an awakening, even though most people need to be awake for at least 2 minutes to remember having been awake. So this person remembered having woken up twice. She actually woke up 23 times. And in addition to 23 awakenings, she had 125 arousals. So her sleep was disrupted almost 150 times, and she was only aware of 2 of them. So these are the kind of data that made me think that the autonomic nervous system was to blame for part of this. Here's a graph where I've just pulled out heart rate and sleep stages. And these tall peaks here, these are all awakenings. And if you took a ruler or even from across the room, you could see that the awakenings almost always line up with spikes in the heart rate. So then, fair question, is it waking up that causes your heart rate to spike, or is it the heart rate spikes that make you wake up? And I think it's the latter, and I'll show you why. So here's somebody, unlike the picture I showed you earlier, where somebody was just stuck in shallow sleep the whole night. This person actually is trying to cycle through deep sleep and shallow sleep and deep sleep and shallow and REM, but you'll see that her deep sleep is just totally broken. Every time she tries to get into deep sleep, she just comes right out of it. Unfortunately, most sleep software is going to add up all these little bits here and say that this person spent 10% of the night in deep sleep, where really this is worthless. Getting deep sleep 3 or 4 minutes at a time doesn't count for anything. So here's a graph where, again, if you took a ruler, you'd see that the heart rate spikes line up with this person had about 20 awakenings. But what's most striking about this, what we call hypnogram, is that for whatever reason, this person's autonomic nervous system was calm and quiet. Her heart rate was nice and smooth for this long chunk of time here early in the night. And she got a nice, long, almost interrupted chunk of deep sleep. The rest of the night, up, down, up, down, up, down. So I put this slide up again to make the point that, unfortunately, something that many of you have probably run into is that this sleep study, which you now all recognize as being quite abnormal, was read as normal by a board-certified sleep. And so this led me to include this slide, whereas here, this is the doctor saying to the patient, the MRI reveals that your head is riddled with conventional wisdom. I think in most cases, dysautonomia and Ehlers-Danlos patients coming out of sleep studies need to be aware of the fact that the interpreting physician's head is likely riddled with conventional wisdom. So that studies, and I just saw a study last week where a similar study, 116 arousals in the course of a night, was not even mentioned in a 6-page report of the study. So there's an interesting phenomenon, troublesome phenomenon for sleep labs, is something called the first night effect. When you're in a strange place, you don't sleep well. That's true of traveling in particular. People just are a little wary. They're not sure what's going on. Their bodies aren't used to whatever background noises are going on. And this has been called the night watch phenomenon, or what I tend to call on alert, which from an evolutionary perspective is literally a protective mechanism to be hypervigilant for threats in a new environment. But in fact, in a study done, I think, at Mass General half a dozen years ago, it turns out that one part of the brain is sleeping fairly normally, but another part of the brain is remaining alert even during sleep. So this group discovered an asymmetry between the 2 hemispheres of the brain and reported that the first night effect is a manifestation of one hemisphere being vigilant as the night watchman to monitor for anything unfamiliar happening during sleep. And that the bigger the difference between the 2 hemispheres, the longer it took somebody to fall asleep. And most importantly, from the perspective of dysautonomia, the hemisphere with reduced sleep depth showed an enhanced or exaggerated response to deviant stimuli, just as my patient with the unexpected hearing the plate fall on the shelf caused this exaggerated, what we call startle response. In this case, the watchful part of the brain caused more arousals and a faster response than what was detected by the other half of the brain while it was during sleep. So in this study, however, then they had people come back the second night, and lo and behold, they found that this didn't happen. Hence the description of this as the first night effect. But what I've found is that in Ehlers-Danlos and the dysautonomias, it seems as if every night is a first night, that you're on alert all the time, that a minimal noise will wake you up and you'll be awake for 45 minutes after that, waiting to calm down again. So the good thing about the interconnection between autonomic dysfunction and poor sleep is that improving autonomic function generally will improve sleep, and improving sleep generally will improve autonomic function. So how do we do that? So we're talking about autonomic dysfunction in sleep, and that's what I'll be talking about for the rest of the talk here. It's important to realize, of course, that autonomic dysfunction and sleep don't exist in a vacuum. With the biggest factors in Ehlers-Danlos patients and any chronically ill patient who doesn't sleep well, being pain and depression. So both pain and depression aggravate sleep. Poor sleep makes you more susceptible to pain and depression. And all of these things drive fatigue and pain tend to be the major drivers of autonomic dysfunction. So all these things are related. So either going to talk about sleep and autonomic dysfunction, pain and depression are major factors also that affect these things and need to be addressed. So, and this you'll recall is the before and after slide I put in. And the question obviously is, what happened during those 18 months of treatment? What was actually done? And in this case, this was a patient who was severely depressed, so exhausted she couldn't get out of bed, really struggling with any kind of cognitive function. So fairly aggressive treatment of pain and her depression, as well as her sleep and autonomic problems. And that's why it took a year and a half. Often these things will take less time than that. So this idea of non-restorative sleep, that you could sleep through the night and wake up feeling exhausted, is a important feature of a lot of the dysautonomias and the hypermobility syndromes. So how do we improve the quality of sleep? I was just said improving autonomic function will improve sleep. So, and as I mentioned, the major drivers of autonomic dysfunction, these syndromes, are pain and fatigue. Dehydration is a factor. Maintaining hydration is a problem. Fluctuating blood sugars, I see in about maybe 15 or 20% of my dysautonomia patients. Hypoglycemia is a major trigger for a fight or flight stress response, and even for increased arousal. And then emotional and cognitive stresses can just cause fatigue and what I call autonomic depletion, which drives autonomic dysfunction. So here's my cartoon version of this analogy or metaphor, is that I find it helpful to suggest that people think about having an energy reserve, having a gas tank, if you will. Sleep is the major chance to put gas into the tank, and almost everything else you do takes gas out of the tank. Pain is a major energy suck. Just people don't realize how much pain they're in. There's a concept of background pain that you just don't notice how much pain you're in. You get to be used to it. But it's constantly a constant energy drain and further disrupts your sleep. Fatigue paradoxically aggravates itself, that when you're tired and you push through it to keep going, to get something done, you're just drawing from reserves and making everything worse. The same thing if you're dehydrated, your body's going to have increased sympathetic activity to compensate for that. Many people realize very quickly that cognitive effort draws from the same fuel tank as physical activity, and that 10 minutes of reading can be just as draining as 10 minutes of a brisk walk. Emotional stresses obviously are tiring. I think we know that. Work, school, financial stresses. Obviously, in these days, societal stresses are a major. Just watching the news on TV can be exhausting because you see political strife and the latest natural disasters and things. To try to understand. So The goal then is to try and refill the pool because, again, as I mentioned earlier, the emptier the pool gets, the more your body overreacts. So, and another unfortunate paradox, the more tired you are, the more you're trying to conserve energy, the more your body is wasting it overreacting to minor things. So to replenish your reserves, we'll get to better sleep. That means for most people, better quality of sleep. I find a lot of people are getting a decent length of sleep. It's just disrupted, too many disruptions and not enough deep sleep. And then adequate pain control is really critical. Again, most people get used to being in a certain level of pain. Say on a 10-point scale, they're used to living at a 4. They don't even notice their pain until they get up to a 6 or 7. And then they'll hem and haw about, gee, my pain seems a little worse. I wonder if I should take something for it or not. Then I tell people that if you even have that thought, gee, I wonder if I should take pain medicine or not, you should, because your pain at that point is already significantly above the baseline level that you're used to. Then trying to recognize that there's pain that's there all the time that you're either not aware of or you don't want to take more medication to control. That can be a hard sell, but if you really don't get your pain under control, it's going to be hard to get a restful night's sleep. It's going to be hard to improve your autonomic. Again, as I mentioned, don't push through fatigue. Sometimes when something stressful happens, some adrenaline kicks in. As soon as that adrenaline kicks in, you don't feel tired, you don't feel depressed, and you don't notice pain as much. So you tend to keep going longer than you should. So I recommend taking frequent breaks. If you take a break and after the break you still feel great, keep going. But often if you take a short break, you'll realize that you really were running on fumes and that really you need to take a longer break before you go back to what you were doing. Adequate salt and fluid is really important. As I mentioned, dehydration is a big driver of increase in sympathetic activity. Fluctuating blood sugars, hypoglycemia is, again, a big impetus for an adrenaline or sympathetic surge. And then, as best you can, minimize emotional and other stresses in your life. So, put in a few slides here to, well, for a couple of reasons. One, to show, again, some before and after pictures, but also to show the value of home sleep monitors. Because given first night effect and just the fact that, who's going to sleep normally in a sleep lab when it's a strange setting and you're connected a bunch of wires and monitors, having a home sleep monitor is very helpful. And finally, we've gotten to the point where some of the Fitbits, for example, have pretty accurate sleep algorithms and can give pretty good data. And then you can look and see if you have an unusually good night, what was different about that night. If you have an unusually bad night, what was different about that night. If you make some kind of intervention with eating earlier, or eating later, or exercise in the evening, or not exercise, you can see the impact of that on the quality of your sleep. So this is one of the first generation home sleep monitors. This is a patient who originally had 231 arousals in 6 hours of sleep. And though you don't see the arousals here, you can see that he had the typical sort of 25 awakenings during the course of the night and just one very short period of deep sleep toward the beginning of the night. This is what his home sleep monitor looked like at the time. Orange is awake. So you can see that he spent most of the night awake. These monitors only took a reading about every 30 seconds, so they probably missed a lot of other disruptions. You can see you get a tiny bit of deep sleep, lots of time awake. And then this is where he got to after about 6 months. And this was a person who couldn't sleep at all night and couldn't stay awake all day. And this is one of the first patients that I put on a beta blocker, in this case, propranolol. And I just at that point said, this has got to be adrenaline that's keeping you awake. And I had him start propranolol at 10 milligrams for a week, and then 20 for a week, and 30 for a week, and 40 for a week. And I saw him after a month, and he said, I don't think this is doing anything. Fortunately, his monitor showed that he was down from 231 arousals a night to 85 arousals, still being a pretty bad night's sleep. When we finally got him up to something like 120 milligrams of propranolol at 8 or 9 o'clock and another 40 or 60 at bedtime, we reduced his arousals to about 10 or 12. And 6 months after starting treatment, he was waking up at 7:30 in the morning without an alarm. So it is important not to overlook the possibility of coexistent sleep disorders. And I'll show you an example of that in a minute. And it's really important that you not overlook the basics. Almost every week, somebody comes in and says, I bought a new mattress and I can't believe how much better I'm sleeping. So good sleep hygiene is important. Don't do anything too stimulating late at night. Don't be checking your email and looking at your phone or watching some cops and robbers or scary movie on TV right before you go to bed. And dark and quiet is important. Again, your body's overly sensitive to small amounts of light and sound. So a sleep mask is simpler than blackout curtains, but noisy neighbors can be a big problem. And then, very importantly, you should look to see if you have sleep apnea and if you have something called periodic limb movements of sleep, but those should only be treated if they're significant. Very often I see people have, say, 125 arousals in the course of a night, and 25 of them are apnea related. Clearly, in such a case, treating the sleep apnea is going to leave the person with 100 arousals and not do anything for the overall quality of their sleep. So this is our cartoon just to make that point that the doctor says no rest even after counting the whole flock. You should be tested for sleep apnea. Sleep apnea does seem to be more common in hypermobile people, but I see a lot of people who have minimal sleep apnea, and that's only a small factor in the poor quality of their sleep. So, non-pharmacologic measures beyond dark and quiet and comfortable mattress and getting rid of your noisy bed partner. So treatment for apnea, if it's significant. A lot of other good non-pharmacologic measures. Guided imagery is the idea of sort of just imagining you're in a calm, relaxing place. Deep breathing can stimulate your parasympathetic nervous system, so that's often helpful to get you to sleep. In my experience, that typically the effect of that wears off in a couple hours. So if you've really got too much adrenaline going, you'll wake up soon after that. Something called sequential relaxation, where you contract and relax muscle groups to get your body to relax. White noise, pink noise. Somebody told me recently about brown noise. Different kinds of background noise can be helpful. Certainly, using alcohol to help fall asleep is a trap that many people fall into. And alcohol is terrible for your sleep. It's initially relaxing and sedating, but then shortly after that, it becomes stimulating. Despite all those things, and your quality of your sleep is still a problem. Then I'd say in the vast majority of cases, people need something pharmacologic. There's something at a very basic level that's not being regulated properly, and non-pharmacologic measures often are not sufficient to reduce what appears to be excessive sympathetic tone overnight. It might be that you don't have enough parasympathetic tone, but we don't have a lot of great medications for increasing parasympathetic activity. We have better options for reducing sympathetic. So, and typically, in terms of optimizing the quality of sleep, most people will need a complex regimen of different things with complementary effects. So, a lot of patients are hesitant to take pain medication at bedtime, figuring, gee, I'm asleep. Why should I take pain medicine then? Not realizing how much pain is disrupting their sleep. They may need another medication to reduce this arousal concept of too much sympathetic activity. They may need something else to increase deep sleep if they're having lack of deep sleep as well. Some people will need an anti-anxiety medication or muscle relaxant, various combinations of things. And finding the right combination can be a frustrating trial and error process, but the home monitors can be helpful. As in the other patient I told you about, if he didn't have the monitor showing that his arousals were reduced from 230 to 85, we would have thought the propranolol wasn't working, when in fact it was. So medications are that improve the quality of sleep in the dysautonomias and in patients with Ehlers-Danlos and similar conditions include medications to block or prevent excessive sympathetic tone, excessive adrenaline secretion, excessive sympathetic activity overnight, to block histamine. A lot of people don't realize that the same histamine that makes your skin itch and your nose run and your stomach overproduce acid is a very stimulating neurotransmitter in your brain. So I see a lot of patients with mast cell disorders who are taking an H1 blocker for the excessive histamine in their skin and their respiratory tract, and an H2 blocker for the excessive histamine in their GI tract, but they're leaving extra histamine in their central nervous system and their brain unchecked. And I've been guilty of this. I learned my lesson once with somebody I think I had tried on 3 or 4 different beta blockers, and finally it occurred to me that maybe it was Benadryl that was keeping her awake, and not maybe it was histamine that was keeping her awake, and not adrenaline. And so I asked her, "Can you take Benadryl?" And she said, "No, I can't take Benadryl. It knocks me out." So I said, "Oh, that's so." Benadryl, I prefer hydroxyzine. Benadryl's a little more likely to cause a next day hangover effect, but these are first generation H1 blockers. The advantage of Claritin and Allegra and Zyrtec, and now Zyzal is also over the counter, are that they were designed specifically not to cross the blood-brain barrier, so they don't make you sleepy. But particularly if you have mast cell disorder, then there's extra Benadryl, there's extra histamine running around your brain, and adding an antihistamine can be very helpful. Other medications that reduce arousal are the benzodiazepines, the newer group of so-called orexin inhibitors. Suvorexant is Belsomra in the US, and there's 2 others now on the market. And again, as I mentioned, pain medications, because pain often is disrupting sleep, keeping you out of a deep sleep more than people realize. And specifically medications to try and increase deep sleep, because as you've seen, the most characteristic features of the sleep disorder in these populations are the frequent arousals and the lack of deep sleep. What most people would consider sleeping pills, I suggest that you avoid or use sparingly, because they don't do anything to reduce arousals or to increase deep sleep. So I'll go through some that I think I won't read for the sake of time, not read every line of every slide here, but we talked about propranolol in this one patient, increasing a dose, switching to a long-acting. Some people will take a 12-hour propranolol typically lasts about 6 hours. So if you're taking it right at bedtime and you're waking up too early, you might need to take a longer-acting propranolol. If you're getting a second wind between 9 and 10 at night, then you might want to take a long-acting propranolol at 9 and then a shorter-acting one right at bedtime. And if a beta blocker at bedtime is helping the quality of your sleep, then you might do well to take a little bit during the day to reduce that tendency to overreact to minor stresses. If propranolol is not effective or is not tolerated, that doesn't mean that beta blockers won't work. You should try a different beta blocker. In some cases, I get lucky and the first one is great. Sometimes it takes third, fourth, or even fifth one to find the beta blocker that's right for one particular person. So other beta blockers that I use fairly regularly, there's a dozen or so, but metoprolol is nice because it comes in, it's also about a 6-hour drug, so it's good at bedtime without worrying about next day hangover. And it also comes in a 24-hour version. So for a lot of people, taking a small dose to take the edge off whatever hyperarousal they have during the day is a useful thing. And then they can add more of the short-acting at bedtime, because you don't want to block, if you block too much adrenaline during the day, you're going to feel it's going to make your fatigue worse. But you really want to block it all at night. So adding more of the short-acting at bedtime works well. Nadolol is a longer-lasting beta blocker. So for people who do get that second wind in the middle of the evening, typically about 9:30 or 10, taking propranolol at between 8 and 9 will often be sufficient to last through the night. Again, a lot of people, once they see a benefit there, will take a tiny bit in the morning, usually taking 20 milligrams in the morning and 3 or 4 times that much in the evening. Carvedilol works a little differently pharmacologically, but it's nice that it's also a 12-hour drug, so you can take a little bit in the morning and a bigger dose in the evening, and it's available in a very tiny dose. A typical blood pressure lowering dose would be about 25 milligrams twice a day. They make a 3.125 milligrams, so it's easy to titrate the dose of that. Nebivolol, I think, is the newest beta blocker. It's a once daily drug, which is nice because you take it, but it doesn't give you the ability to add more in the evening. But for a lot of people who are intolerant, for example, other beta blockers can be a problem in people with asthma, whereas nebivolol doesn't seem to affect asthma. And I have a number of people who, and here again, just as an example, I saw a couple people in the past week, one on 1.25 milligrams of nebivolol, which is half of the smallest dose, another just on 2.5 milligrams, and another woman who takes 20 milligrams twice a day. And at that dose, her blood pressure is about 98/62, and she feels great. And people look at her and say, "Why are you taking all this blood pressure medicine? The blood pressure is so low." And she just looks at them and says, "You wouldn't understand." So clonidine and guanfacine are different in that, whereas the beta blockers generally are sort of blocking adrenaline that you've already made, these drugs suppress it so you don't make it in the first place. So clonidine was one of our first blood pressure medicines now, maybe 70 years ago, and sedation and fatigue were a big problem. But clonidine at bedtime can be a very good shut off of excessive sympathetic tone, and is safe to use in asthma, has no effect on breathing. So most of the time people need, one or two of the 0.1 milligram tablets. It's rare that anybody, I have a couple people who take 0.3 milligrams. And then I have a couple people on a 24-hour week-long clonidine patch because they're just in what they just call sympathetic overdrive night and day. And this keeps them calm, regulates their sleep. And there is now an extended release clonidine marketed primarily for the treatment of ADD. It comes in very small doses. So 0.1 milligrams gradually released over 12 hours doesn't have a lot of effect, but I have a handful of dysautonomia patients who find that helpful. Guanfacine is a similar drug designed to act like clonidine, but to last longer. For blood pressure control, clonidine had to be taken 3 or 4 times a day. Guanfacine was designed as a once-daily drug. And again, it had also been rediscovered as a treatment for ADD, supporting my contention that ADD is probably an autonomic problem and not a psychiatric one. So alpha blockers, as the name suggests, epinephrine, adrenaline, or its cousin norepinephrine, binds primarily to beta blockers, and beta activity stimulates increase in heart rate and increase in blood pressure, increase in the force of contractions of the heart. Binding to alpha blockers, binding to alpha receptors causes blood vessels to constrict and raises blood pressure. But alpha blockers aren't used to treat high blood pressure anymore because alpha blockers cause blood vessels to dilate. That causes blood pressure to drop. And guess what? That triggers an increase in adrenaline, increase in beta activity. So now it's not very helpful for the management of hypertension. But it turns out that people who have vivid dreams, nightmares, seem to be associated with binding of adrenaline to alpha sites in the brain, and that alpha blockers have been found to be very effective in the treatment of PTSD. In a VA study done now probably 15 years ago, the success rate was almost 80% of troops coming back from the war with flashbacks and nightmares, and in completely getting rid of them. So that's where most of this literature comes from. There have been some more recent studies showing that other alpha blockers have similar effects, but most of my patients take prazosin, and that's been the best study. Yet another paradox here is that when these used to be prescribed for blood pressure, one of the major side effects we would warn people of was lightheadedness. And yet, paradoxically, in this patient population, tends to be lightheaded most of the time. Often anyway, is rarely a problem. And it may be because people who are prone to lightheadedness don't jump up out of bed in the middle of the night or don't stand up quickly during the day. But in any case, I would say somewhere in the range of, again, 15 to 20% of my dysautonomia patients end up benefiting from addition of an alpha blocker. And these are people who will say, oh yeah, I have, if you can wake up in the morning and remember several different dreams you had during the course of the night and remember the details of them, then your brain was too awake. That's not right. You wake up in the morning and you were having a dream and and 5 minutes later you've forgotten it. That's normal, but that's not what I hear from a lot of patients. So usually I use prazosin starting at a milligram. Most of my patients end up in the range of about 3 to 5 milligrams. The VA study was most people were getting closer to 10. I don't have a few patients even on 15 milligrams, but most people are in the 3, 4, 5 range. And as is the other alpha blockers, terazosin and doxazosin, appear to have similar benefits. Doxazosin causes more lightheadedness because kind of like the differences between clonidine and guanfacine, doxazosin was designed to be a longer lasting drug. So it lasts well into the next day. And so I tend not to use it for this type of sleep problem. Terazosin was marketed as Hytrin. It's used as a treatment for benign prostatic hypertrophy. So very helpful for men with enlarged prostates who are getting up several times at night. So sometimes that can be in their rare older male patient who has these issues and kill two birds with one stone. But it is an intermediate acting. It lasts a little bit longer than the prazosin. I have a few patients who waking up at 5 in the morning with very vivid dreams, seemingly corresponding to when their prazosin is wearing off. So I have a couple of patients who've added a little add a little terazosin to their prazosin to get them through those last few hours. Interestingly, the blood pressure medicines like Adderall that have alpha activity don't seem to have this benefit, don't seem to produce the dreams and the nightmares. So benzodiazepines are drugs in the Xanax, Valium, Ativan, Restoril, Halcyon family. They can be helpful because they're a sedative, they have anti-anxiety properties, they have some muscle relaxant properties. They reduce extra movement at night. They basically work by raising the levels of calming chemicals in your brain to offset the extra stimulating stuff that's keeping you awake and disrupting your sleep. But they have significant downsides. They certainly impair cognition. They impair motor performance. So you really want to be careful about taking any of this during the day. They're downers. They can depress mood. They can make fatigue worse. They can depress respiration. So you have to be very careful about using them with any other medications that can depress respiration. And they can cause fatigue. They can make you feel just run out and exhausted. And they have the potential to cause tolerance, dependence, and withdrawal. Fortunately, I very rarely see that with patients taking the benzodiazepine just at bedtime. I almost never see people develop a tolerance. They don't develop tender dependence, and they don't go through withdrawal if they skip it right. So just for sort of sake of completeness, again, I won't read every word of all these slides. I will make the point that clonazepam, which is widely used in the sleep community because it helps with anxiety and helps with movement disorders and has muscle relaxant effects and has sedative effects. So it's good for almost anything that could be wrong with your sleep. Also can last up to 12 hours. So I've seen a number of patients over the years who wake up exhausted and drag through the whole morning, finally start to wake up around noon. And it turns out that they're not groggy all morning because they haven't slept well. They're groggy all morning because their bedtime clonazepam hasn't worn off yet. So diazepam is used because it's probably the best muscle relaxant of the group. Some of the neurosurgeons tend to use it for its muscle relaxant activity post-op. Restoril, the few patients use it, was marketed as a sleep drug because it lasts about 7 hours. I'm not a big fan of that. My favorite of the group is lorazepam because it's metabolized differently, so I don't have to worry about some people being shorter, chewing the drug up faster than they should, or having it last longer than it should. It typically lasts about 6 hours, can help fall asleep. It's gone by the morning. There's no tendency to accumulate or build up tolerance or anything like that. But again, you should stay away from the benzodiazepines if you can. Pain medicines are important. As I mentioned, most people tend to underestimate how much pain is disrupting your sleep. The anti-inflammatories, a lot of people find helpful. Certainly, Ehlers-Danlos, I often make the point, is not primarily an inflammatory disorder. So a lot of people are surprised why they're, ibuprofen doesn't do much for their pain. Yeah, certainly other physicians, sometimes it's the rheumatologist, sometimes it's the ENT, sometimes it's the orthopedist, putting people on steroids for various reasons without really considering how bad they are for your sleep. Um, um, some people find Tylenol, taking a couple Tylenol at bedtime helps them sleep better. Um, Tramadol tends to be a hit or miss drug, but I'm always surprised by the number of people who do really well with it. I've put it here with acetaminophen because it's really closest in safety and tolerability to acetaminophen, though unfortunately insurance companies are now considering with the opioids. Uh, in fact, tramadol is 1/80th as strong as morphine. So you really have to take a lot of tramadol to have any kind of respiratory depression or significant opioid effect. Uh, some people do need opioids. Obviously, this is controversial. There's people claim, well, there's no literature that says, that opioids are effective for the treatment of long-term non-cancer pain. And that has to be just because people haven't studied that. Because um, sometimes I've even been known to give people a prescription for, 4 or 5 uh, Percocet or Vicodin or something like that, just to take at bedtime as the simplest way to see how much pain really is disrupting their sleep. And the vast majority of those people are really surprised how much better they sleep. Um, and again, bedtime only dosing tends to and doesn't really cause any problems with dependence or tolerance. Important drugs in the management of chronic pain associated sleep problems are um, gabapentin and pregabalin because they're effective both for pain and they're non-narcotic, and they're among the few medications shown to actually increase deep sleep. Um, uh, Duloxetine and milnacipran, which is Savella, and then marketed as a antidepressant as well under the brand name Fetsima, are drugs that have effects both on depression and pain. So they can be very helpful um, uh, in people. And we know that chronic pain is associated with depression. So those are medications that should be among the first things that people with chronic pain are trying. Topical medications can be helpful, but most people's pain is fairly widespread, and so it's not really a mainstay of pain management. Muscle relaxants, I just throw these in because just to make the point, different things work for different people. These all ostensibly have different sites of action. Some we think work in the brain, some we think work in the spinal cord. They're metabolized differently in terms of the breakdown pathways that the body uses to break down the medications. They have different side effects. The Flexeril is the one that's been sort of tried and true. That's been shown to improve sleep quality in chronic pain syndromes like fibromyalgia. And the only other one I'll point out here is baclofen, which I see a lot of people put on. And I point out that the FDA indications, the package insert, specifically recommend that it not be used for the treatment of musculoskeletal pain. It has a nasty withdrawal syndrome. I just one that I tend to stay away from. Antidepressants, again, the idea that depression affects pain, sleep, fatigue. So it's a part of this puzzle for most people. One thing that most people, psychiatrists included, don't realize is that all the serotonin drugs cause a shallower dreamier sleep. That's just the way they work. By increasing serotonin, you have a shallower, you have more, you feel less sluggish during the day, but you're a little more stimulated overnight. Prozac generally is the worst. Lexapro seems to affect sleep at least. In all of these cases, I tend to recommend people use the smallest effective dose. I see a lot of patients who say they can't take these drugs because they make them sick or they make them nauseous or they make them feel drugged or spacey. And to me, that just tells me that they've been taking too much. And a lot of times reintroducing these drugs at a much smaller dose. Again, Lexapro is my favorite here because it's commercially available as a liquid. So whereas the standard starting dose is 5 to 10 milligrams, with a liquid preparation, I can start with 1 milligram or sometimes even less, and very gradually increase their dose. Duloxetine, again, relieves pain, should be taken in the morning. It's been shown not to affect sleep. somewhat surprisingly, since it has a serotonin effect and it has a norepinephrine effect. If taken in the morning, but I would try not taking it in the evening. Um, Milnacipran also has pain and mood effects. It tends to be a little more stimulating. I have occasional patients. Savelo is marketed as a fibromyalgia drug, as a twice-a-day drug. I have some patients who can't take an evening dose because it's still too stimulating. They just take a morning dose. The Fetsima is an extended release drug of the same compound. Tricyclic antidepressants can improve sleep. Low-dose amitriptyline can help, especially if chronic pain is a factor in poor sleep. At regular antidepressant doses, they're too sedating and have too many other side effects. Bupropion is a very helpful drug. Helps with mood, helps with motivation, helps with energy, can help with cognitive symptoms, can help particularly with motivation. If you just have the inertia of chronic pain and poor sleep and just easily get stuck in the vicious cycle of the worse you feel, the more you sit around, the more you sit around, the worse you feel. The problem with bupropion is that a number of years ago, because people were forgetting, it was marketed as a twice-a-day drug, people were forgetting to take their second dose, so they made a once-a-day formulation. Problem is that bupropion is the most energizing and stimulating of the antidepressants. The most common side effect is insomnia, so you really don't want stimulating effect overnight. So many of my patients take the 12-hour version just once in the morning. It helps them feel better through the course of the day, wears off by late afternoon, early evening, when that's when they're winding down for the day anyway. For people who metabolize it a little more rapidly, the morning dose can wear off at 3, 4 in the afternoon, just when they really need it to help them get through a late afternoon dip. And those people will take a dose, one in the morning and one about 6 hours later in the early afternoon. So even the twice-a-day version is not a morning and evening, it's a morning and an early afternoon dose. And that's something that a lot of people do well with. Mirtazapine is an interesting drug. It's a mild antidepressant. Again, on the very short list of medications that's been shown to increase deep sleep. Essentially, it has an antihistamine effect, and that's probably how it improves sleep. It also can improve appetite and can cause weight gain. So a lot of times we stay away from it in younger people, but I do see a fair number of young people who, because of high sympathetic tone acting as a stimulant, it increases their metabolism and suppresses their appetite, and they really have trouble maintaining their weight. So the paradoxical thing about this is it's more helpful in improving sleep at low doses. It's more stimulating at higher doses. So for the sleep effect, you want to stick to 7.5 or 15 milligrams and not go any higher than that. So other agents, trazodone, most important on this list, seems to be the best thing we have for increasing deep sleep. Particularly in people on serotonin drugs, it seems to have an anti-serotonin effect. So you have serotonin medication tend to give you a shallower, dreamier sleep. Trazodone offsets that and gives you sleep. And similar to amitriptyline, you're taking much smaller than the antidepressant dose. Antidepressant dose is 300 to 450, and most people take only 50 milligrams for their sleep. Amitriptyline mentioned. Doxepin is an interesting drug that may also increase deep sleep. It was the antidepressant dose, again, is in the 200, 250 milligram range. Somebody discovered that it had beneficial effects on sleep at very small doses and got a new marketing and licensing agreement for 3 and 6 milligram doses under the brand name Silenor. But it is commercially available as a 10 milligram tablet and also as a liquid. So can allow small dosing and titrating, and probably less expensive than the 3 and 6 milligram tablets. And I already mentioned antihistamines as being helpful, particularly in people with mast cell disorders. The sleeping pills I mentioned, stay away from the sleeping pills because, again, they don't reduce arousals, they don't increase deep sleep. Zolpidem typically wears off in 5 hours and can aggravate any tendency to have early awakening. Some people need one of these medications to help them fall asleep, but they're going to need a bunch of other things to improve what else is wrong with their sleep, because these are not helping the basic problems of their sleep. So, question I've gotten for, I was going to say years, I probably should say decades, is do I have any data? I wish I'd kept a tally sheet of how many patients I've put on beta blockers in the last 15 or 20 years. But there's a handful. I joke that the only real data I have are the two-legged kind. because I'm clearly not going to do a placebo-controlled trial. So one of my patients started propranolol and said she was stunned, amazed, and grateful at the benefits. Improvement on sleep quality alone is fantastic. Another patient said, medicine you gave me is amazing. 2 worked great, 3 worked even better. I forgot to take it one night. I slept 12 hours and I felt terrible. Next night I took it and I slept 6 hours and I felt great. Another patient I've known for a long time said that metoprolol was the drug that helped her sleep. She would take combination metoprolol, Flexeril, and ibuprofen and fall asleep, stay asleep, and seem to get a much better quality of sleep. And then somebody actually just spoke to this week who we played around with different things and finally ended up realizing that what she really needed was an alpha blocker, not a beta blocker. And she, at some point later, sent me a note saying she wanted to let me know how much the Brazen was helping. I'm sleeping better now than I ever have in my life. If I get 7 hours of sleep, it's always uninterrupted. And I wake feeling rested and ready for the day. It's changed my life. So in conclusion, in summary, I hope I've shown you that the most common type of sleep disorder we see in hypermobility syndromes and related dysautonomias seems to be characterized by excessive sympathetic activity at night, which both disrupts the continuity of sleep and keeps people out of deep sleep. So medications to suppress or offset or block this excessive sympathetic activity are effective in improving sleep quality as measured both by sleep studies and by patient reports of symptom relief. So go back to this and the answer to the question of what do I have to do to get better? This is the slide I usually tell people. You need to work on everything at once. You need to work on your sleep, but you need to work on improving your autonomic dysfunction by minimizing all the stresses that are draining energy, recognizing this paradox that the more run down, the more exhausted, the more overtired you become, the worse your autonomic dysfunction becomes, the worse your sleep gets. And then you're stuck in an awful cycle where you wake up tired from not sleeping well. Your body kicks up a sympathetic tone to keep you going, to fight the fatigue. And then your high sympathetic tone gives you another crummy night's sleep. And that cycle we need to break. So improving sleep and minimizing the daytime stresses is going to help to fill up the pool, to replenish your autonomic reserves. That in turn will improve your daytime autonomic balance, and you'll have more energy. That will help your sleep. That will help your daytime function. The more active you are during the day, better you're going to sleep at night. And that in turn is how people start to feel better. So hope that was helpful. Thanks again to the Dysautonomia Support Network for inviting me to do this and helping to spread knowledge and understanding of these poorly understood areas that particularly physicians don't seem to know much about. I always thank my friends and colleagues, Peter Rowe and Dave Goldstein, for encouraging me when I first floated these ideas now a couple of decades ago. And everyone else in the room thought I was crazy. And fortunately, the two of them came to my rescue and said, no, you're not. And my colleagues, Dr. Frank Amano, Dr. Henderson, Dr. Rodney Graham, who first essentially introduced me to Ehlers-Danlos and taught me a lot about it. And then lastly, I always thank my patients because, as you might have gathered from the data I presented, most of what I've learned about this, I've learned from experimenting on my patients. So, well, this seems to make sense to me. Why don't we try it and see what happens? Thank you again. Hope this was helpful.